bunyi ke? I don't think ada bunyi.
Semua betul. How many percent?
Bunyi lah, bunyi. Ini bunyi. Okay,
100%.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Very good. Apa? Afternoon. Late afternoon. Hope you can bear with me. The title itself is OSA. So those who have OSA dah lepas makan, dah towards the end of the day, I hope you wouldn't fall asleep lah. Okay. The topic that is given is adult OSA. This picture is recently taken in a patient who has ligamental tear, meniscus tear, undergoing surgery. So Datuk Badrul, Marina, can you do anything for this patient so that the case wouldn't be cancelled? So 3 days before surgery, admit the patient, do polysomnogram, severe OSA, terus buat CPAP trial in the ward. Okay, day 3 buat operation. So the case was not cancelled. And the patient was so happy with the CPAP. Even daytime kita pergi visit dia dekat ward kan, he was sleeping daytime with the CPAP. I was so happy he get a quality of sleep. That's just an introduction. So with the current lifestyle and eating habit lead to obesity. If you have a seafood lah, fast food, once in a month, maybe okay. But every alternate day, with very minimum physical activities, obesity is the issue, which is the main predisposing factors for OSA. And OSA cause significant problem, causing cardiovascular complication. We will talk more about this. Road traffic accident, marital disharmony, and on-job injury. And it may cause sudden nocturnal death. Okay, Prof Sandi's, this is very close to Prof Sandi's heart. In his Syarahan Perdana, what is the title of his Syarahan Perdana? Sleep apnea, the silent killer. Okay, because nocturnal death. There are many people, increasing number of youngsters or middle age or in the 30s who died in their sleep. Okay, that may be caused by OSA, but it was undiagnosed because of lack of awareness. So the outline of the lecture, just briefly for you to understand what is sleep physiology, definition of OSA, what are the risk factors, complication, diagnosis, and followed by treatment. So that you all wouldn't sleep, this is my son. Nak buka mata sikit lah, my son. At that time he was in primary school, Zain. Yeah, he was deeply in sleep. And those who don't, who said that I'm young, he is now 22-year-old. So that's our Indonesian delegates or participants. This is my son. It taken last night in the airport. He had safely arrived at Istanbul. And dekat KLIA semalam ada banjir kilat penuh dengan air mata. And this is my children. So the apa ni, yang tengah-tengah ni kan, the youngest, Umi, please take picture 3 of us and change your home screen photo. So I've done it. Ada tukar my home screen photo, mesti ada gambar abang dekat situ. So she's very close to abang. And she woke up this morning sitting for UPSR. Taken by the teacher. And that's her yang pakai cermin mata. Okay, briefing sebelum UPSR. So she woke up with mata yang bengkak-bengkak as the mother. Bengkak-bengkak. Mandi nangis sampai nangis je. 1 year je. Bukannya lama sangat pun. The most 2 years kalau he sit for ACCA after that. Okay, now what is sleep? Right? It is a cyclical and episodic phase which alternates with wakefulness. So sleep is not just sleep. It is cyclical. There are phases, there are stages. What are the 2 main stages? Number 1 is non-REM, non-rapid eye movement. Okay, another one is REM. Which one is more? Non-REM or REM? Throughout your sleep? Non-REM, which is 3/4. Okay, and REM is just 1/4 of the sleep. And REM is known as internal arousal. This is the time people dream. You get nightmare, you masa-masa REM sleep. During the non-REM, the first stage, second stage, it is a light sleep. Okay, but when you go into third stage, fourth stage, you go into deep sleep. This is the time your growth hormone, rejuvenation, repair of tissue occur. And this is the time normally obstructive events occur. When the muscle is totally relaxed, collapsed, plus all the risk factors, fat neck and everything. So you get, the patient get obstructed, hypoxia, wake up, and then go back to stage 1, stage 2. So never get stage 3, stage 4 beautifully. So therefore, they tidur 6 jam, 7 jam, 8 jam pun still not a good quality of sleep because they lack of stage 3 and 4 of the deep sleep. So this pie chart depicts REM sleep only 1/4, the rest are all non-REM. And this one I would like you to understand, as the night become longer and longer, the REM, see this black thing? The REM become longer and longer, the non-REM become shorter and shorter. Okay, so you see every cycle, each cycle, stage 1, 2, 3, 4, and it goes to REM. That one takes about 90 minutes. Okay, those with OSA, they never go to this stage. Stage 1, 2, arousal, go back to stage 1 and 2, go back to stage 1 and 2. They never get good sleep. So that's why they tend to get daytime somnolence, and during the hypoxia, a lot of physiological things happen, which we're going to talk more about this. Now, we get to the main topic of the lecture, which is OSA, obstructive sleep apnea. So what is OSA? It is characterized by repetitive episodes of obstruction of upper airway during sleep, which results in fluctuation of blood oxygen saturation and disruption of sleep continuity. So there are two terms over here. One is apnea, another one is hypopnea. When the obstruction is not complete, that is hypopnea. So whenever the obstruction is complete, it is called apnea. The main presentation is snoring and daytime sleepiness. Okay, rarely dia kata, doktor, saya tidur malam, saya berhenti bernafas. Rarely they complain like that, kan? They say, doctor, I snore at night. Normally dia kata, my wife complain that I snore at night and I have daytime sleepiness. I slept behind the wheel or had accident because I dozed off when I was behind the wheel. So is snoring equivalent to OSA? No. Because there is a such habitual snorer, when they just snore, the pharynx just flutter, especially the soft palate, but the airway is not obstructed. So they can be habitual snorer. So like you observe in this patient. That is apneic episode. Okay, and then just breakthrough, and then breathe again. Alright, so that is apneic episode. This is not so bad. In some bad cases, they even like that, arouse and then go back to sleep. Right. So main cause of obstructive event is due to pharyngeal collapse. Of course, that some cases, in small proportion of cases, they have base of tongue collapse, they have epiglottis collapse, but majority of cases are pharyngeal airway collapse. What are the causes? Number one, in obesity, they have pre-existing tissue laxity and they have redundant mucosa of the fat. They tend to get pharyngeal airway collapse, especially in stage 3, stage 4, when the muscle is really relaxed and become atonic. When increase with age, as the person become older, the tissue elasticity become less, so that the mucosa is collapsible into the airway. People with anatomical abnormalities, reduced muscle tone during the REM sleep. Okay, this one I have mentioned already. However, with reduced muscle tone, especially stage 3, stage 4, non-REM, plus when the mouth is open. Tongue retro displays even more. There is a study looking at dah masuk waktu Okay, not yet. Itu masa Padang punya masa asal. Okay, what did I say? There is a study looking at the airway when the tongue is in, mouth is closed, and when the mouth is open and like that, the airway at the base of tongue is smaller. So therefore, when someone has blocked nose, they breathe with their mouth. When they are sleeping, they tend to get collapsible airway at the pharynx even more. And alcohol intake also contribute to pharyngeal airway collapse because the alcohol will reduce the activity of upper airway dilating muscles. Alright, so does the body sedative intake. Another one is body position. Right, there is another term UARS. UARS is when the symptoms are like OSA, but when a sleep study is performed, it is normal. So this is because increased ventilatory effort due to upper airway narrowing, leading to symptom of OSA, but then there is no apnea, and though there is no oxyhemoglobin desaturation. But this is definition of upper airway respiratory syndrome. Okay, they have symptoms like OSA, but then the sleep study doesn't really show. Okay, and another one is central apnea. Okay, this is why when you do sleep study, it is so important to have the belt, the sensor around the chest. This is to differentiate between respiratory obstructive event and central apnea. Someone who have obstructive sleep apnea, when the obstruction occur, the chest keep on moving, trying to breathe. Okay, but in central apnea, because the central said don't breathe, it is just quiet. The chest, there's no movement, there's no effort of respiratory, there's no respiratory effort. So this is when the sleep study will detect detect central apnea. Alright. Okay, next, what are the risk factors? I think most of the people, participants in this hall would know this very well. Number one is obesity. Obesity, I have mentioned, pharyngeal narrowing because of increased fat deposition in soft tissue, tongue, lateral pharyngeal walls. Number two, neck circumference. Kushida et al. Said that, documented that in the research, that regardless age, when the neck circumference is more 17 inch or more than 40 centimeter, the sensitivity is about 61%, specificity is about 93% for the person to get OSA. Alright, male more than female. Craniofacial anomaly such as Cruzon syndrome, Pierre-Robin syndrome, Treacher-Collins, and someone like this who have receding chain, which is very common in Asian population. So that's why there's a surgeon in Singapore. His name is Goh Yao Hong. He said for Asian population with this kind of chin, you cannot afford to have your BMI more than 23. More than 23. If you go beyond 23, you would start having this OSA, snoring and OSA. So therefore, his practice is every day they climb 9 flight of stairs. So to maintain his BMI 23. Alright, another risk factors: adenotonsillar enlargement, nasal blockage, polyp, dilated nasal septum, inferior turbinate hypertrophy, microglossia, elongated uvula, and so on, as shown in these pictures. Right. Before we talk more about treatment, I want to talk a little bit on complications. What happens in patients, physiological disturbance or changes during sleep when OSA occur, when hypoxia occur. So you look in this diagram, okay, the flow chart. The sleep onset, someone have apnea, okay, and the hypoxia, increase in carbon dioxide. What happened? Acidosis, pH reduced. Because of this, these problems occur. Vagal bradycardia, ectopic heartbeat. This can cause nocturnal death. Pulmonary vasoconstriction, in the long run, patient would get pulmonary hypertension, right heart failure. Systemic vasoconstriction, in long run, patient would get young hypertension. Stimulation for erythropoiesis, patient will get polycythemia. What is this syndrome called when someone is so obese, hemoglobin is so high, hypoxia, chronic hypoxia? What is it called? Start with P? Yes, Pickwicken syndrome. Alright? And then because of this, the brain will tell, oi, hypoxia ni, please wake up. So there's arousal from sleep. Then resumption of airflow, patient go back to sleep. But this arousal of sleep occur again and again. What happens when this occur repetitively at night? Someone with AHI, apnea hypopnea index of 40, means about 40 times in 1 hour. This thing occur again and again. Patient will get cerebral dysfunction, loss of deep sleep, sleep fragmentation, daytime somnolence, depression, loss of interest in life, marital dysfunction, and so on. So there are so many complications or sequelae following OSA. So therefore, first to identify these patients are the risk factors, diagnose OSA and treatment. It is pertinent, it is utmost important. Okay, how would you diagnose? I don't have to go through in detail. History, physical examination and investigation. What I want to stress on the history is the history mainly from the bed partner. The patient selalunya tak mengaku. Okay, they will say I have snoring, kan? But then, how would you get history of apnea from the patient? Okay, if the patient doesn't have a sleeping bed partner, you want to ask whether do they suddenly cough at night, tiba-tiba terbangun, batuk. Okay, that is one. Number two, do they go visit the bathroom regularly at night, meaning they have nocturia, unless they have uncontrolled diabetes mellitus. And you also need to get history of other causes of sleepiness. You cannot assume that the daytime somnolence is due to OSA. There are so many other causes that can cause daytime sleepiness that you need to find out in the history. Is the patient doing shift work? Tak tidur malam? Memanglah mengantuk siang, kan? Is the patient nursing baby? Asyik jaga malam because breastfeed? Memanglah mengantuk. Is the patient having some medical problems that cause fatigue, anemia? Okay, that would instead of actually daytime somnolence, the patient has fatigue problem, because of medical problems. Physical examination, look for these factors, look for possible causes, and look for any complication that has occurred due to OSA, followed by investigation. This is a list of medical conditions that may produce fatigue. Right, there's a list of things. You may not, janganlah sampai 30 hours just looking into this. Ask whether any possibilities, any admission, any investigation done before because of these medical issues. Alright, so in physical examination, look for tonsil grading, Friedman tongue position. I will show pictures of this, cardiovascular and central nervous system. Right, this is tonsil size, right? Everyone, I think, familiar with this, grade 1, 2, 3, and 4. And this is Friedman tongue position. By the way, this is an old classification. There is an updated classification of Friedman tongue position. I will show after this. But what I want to stress out here is Friedman tongue position is not equivalent to Malampati. What is the difference between these two? Tongue, position of the tongue. Malampati, open mouth with tongue protruded. But Friedman tongue position with tongue relaxed in the mouth. And you look at the height of the tongue in relation to the soft palate, to the arch of the soft palate and also uvula. Right, another thing apart from tonsil size, apart from tongue position, you need also to evaluate the base of tongue, which most of the time you forgot to look at this. The lingual tonsil, okay? Someone like this is good. Number 2, let's start some lymphoid tissue. Number 3, more lymphoid tissue. Number 4, this is hypertrophic lingual tonsil. And number 5, consider epiglottis at all. Okay, so someone like this and like that is at higher risk of having OSA, especially this person have receding chin. It can be multifactorial. So therefore, the assessment have to be comprehensive. Right. That is about ENT examination. Of course, you have to examine the nose, look for any polyps, deviated nasal septum, hypertrophic, what we call nasopharynx adenoid tissue. Now, investigation. Polysomnography is essential for diagnosis of OSA. And lab polysomnogram, which is level 1, is the gold standard. But it is time consuming. Okay, time consuming, and not all center can provide this. Yeah, this is mainly provided by respiratory team. But I do agree some ENT service also provide a full PSC. What does it mean? It is attended lab polysomnogram. What is lesser than that is type 2, type 3, type 4. So type 3, the one that we normally performed in our patients, has minimum of 4 channels, including ventilation or airflow, okay, which is respiratory movement and airflow here, and respiratory movement to heart rate and oxygen saturation. Okay, minimum 4 channels for you to diagnose OSA. So when do you say no, I wouldn't request for type 3 level 3 home PSG or in the ward PSG level 3, but I would send the patient for level 1 instead. When there is clear cut, this patient has OSA. Clear cut, the patient is snoring. Clear cut, the patient has risk factors of OSA. You can confidently send the patient for level 3. But from the history, it's not clear cut the patient has OSA, although the patient has daytime somnolence. Like the history sounds like narcolepsy. Okay, the patient does not have snoring. Bed partner pun tak ada snoring, tapi mengantuk. Yeah, patient not taking any drugs, not alcohol, the sedative intake. Okay, or the patient has multiple comorbidities that may affect the accuracy of level 3. For example, patient has cardiovascular problems, has COAD, okay, has heart problems as well, heart failure. So you wouldn't want to send just for level 3. It would be inaccurate. You would want to send the patient for level 1 PSG or at least level 2 unattended. Okay, so this is general classification of OSA. Mild for AHI 5 to 15, moderate 16 to 35, severe more than 35. Of course, if you read the literature now, parameters for OSA is not just AHI. There are a lot more. Yeah, you have to read in the literature that can't be covered everything in this lecture. So this is the proforma that has been used in our hospital. Those patients with suspect OSA, we would fill this up, look for risk factors, and then follow up the patient. You can find this in our clinic. Now, the treatment. How do you treat these patients? The treatment goal is to reduce morbidity and mortality, improve quality of life, and you have to counsel the patient regarding increased risk of motor vehicle accident, on-job injuries, impaired judgment if this problem is left untreated. Okay, some patients are so reluctant. Tak ada apa-apa lah doktor. Reluctant to go for sleep study, so reluctant to try on CPAP, so reluctant to have treatment. Okay, so the mainstay of treatment, mainstay. So although this is arguable, some surgeons kata no, I think CPAP is not the way. We have to offer surgery first. But some people said no, CPAP is it. So it is arguable. However, it is quite acceptable if you say that at the moment the mainstay of treatment is still CPAP. Okay, continuous positive airway pressure. CPAP is sometimes is what you call that generic name that is given for positive airway pressure. But actually, there are few types of CPAP. Okay, what I want to say here, although we say that CPAP is the gold standard, but it is only successful, okay, we can say the success rate is more than 90% if the patient is compliant. Meaning, The CPAP would be able to protect the heart, prevent stroke, prevent nocturnal death, prevent heart event if the patient compliant to it. What is the definition? Minimum of 5 days, and each night they use it minimum of 6 hours. Then only it can be considered successful. So the prerequisites before you prescribe CPAP, you have to examine the patient. This is the purpose you do physical examination. For example, the patient has very bad allergic rhinitis. You cannot just give CPAP and that's it. You go and use it at home. You have to treat the nose. They would be able to tolerate the nasal CPAP, the nasal mask, if the nose is congested. You have to treat the nose. Yeah, look for, are you dealing with vasomotor rhinitis, allergic rhinitis? Is the nose is so blocked because of deviated nasal septum, you may want to do surgery. Okay, or the patient have any other obvious anatomical obstruction. Alright, so CPAP acts as pneumatic spleen. As I said, CPAP is like a kind of generic name, but there are a few types. Yeah, non-auto means there is one pressure for the whole night. Okay, not many patients can tolerate this, and it is best for, if you want to use non-auto, for you to send for titration. You understand about titration? In the lab, sleep lab, titrate what is the optimum pressure that this patient needs. Okay, and then use that pressure. Okay, and non-auto normally it is cheaper because one pressure, dia tak boleh flexible. The one that we have been prescribing and doing CPAP trial right now, nowadays is auto titrating. We call it APAP, automated positive airway pressure, APAP. That one, it is flexible according to the need of the patient. Yeah. Another one is BiPAP for more complicated case. So it is a pneumatic splint, positive airway pressure that opens up the airway throughout the night if the patient wears it, use it, so that the patient wouldn't snore and the patient would have enough oxygen the whole night. Another treatment, so CPAP, for as far as my practice, CPAP I normally offer, okay, in cases moderate to severe apnea with no obvious obstruction, okay, and treat the nose if the patient have allergic rhinitis, okay. But if the patient has what do you call that, obvious anatomical obstruction, for example big tonsils, nasal polyposis, there is still role of surgery, but you have to tell the patient, if the SIP study shows that we are dealing with moderate to severe OSA, the surgery may not be able to cure the OSA but may reduce the AHI. The patient may still need to wear the CPAP after the surgery. That is something that you have to warn the patient. Another way of treating is oral appliance therapy, the mandibular advancement device. There is strict criteria for not all patients are suitable. Okay, as far as could remember, the BMI shouldn't be more than 30. The lowest oxygen saturation shouldn't be less than 80%. Okay, then the patient may be suitable for this MAD. So I mentioned about surgery just now. What are the indications when there is clearly reversible cause, big tonsil? We talk more about this, about treatment staging. Patient who refuse CPAP, rather than we don't treat at all, we can do some surgery to at least reduce the AHI. Patient who failed CPAP or refuse CPAP. Okay? Right, so this is the list. I'm not going to go through one by one about this. I can divide non-surgical and surgical treatment. Okay, I think all of you were familiar with this. So just a little bit, something that we don't do anymore in this hospital, uvulopalatopharyngoplasty. Okay, introduced by Ikematsu in 1964. 1964 Ikematsu described first surgical treatment, and 1981 Fujita introduced UPPP. So what is UPPP? You remove this quadrant together with uvula, okay, and the end effect you would get like this: no uvula, remove part of the soft palate until there, and approximate all the mucosal edges. And in the clinic of the healing process, this is how it looks like: no uvula, shortened soft palate look like bigger airway, isn't it? But we found that based on retrospective review of our center, we found that this U-triple-P come with complications. What are the complications? Pain tu memang lah. Even any other pharyngoplasty, patient would have post-op pain, okay, but the one that we do not like is velopharyngeal incompetence. The patient becomes wow, okay, and without uvula, the patient complain more of foreign body sensation because God created the uvula to swipe or to channel mucus from the nose to your pharynx and downward inferiorly. Without the uvula, there's nothing to swipe because the mucus remain in the pharynx, so you feel foreign body sensation. And some of them develop nasopharyngeal stenosis, cicatricious scar, because of the U-triple-P. Therefore, we have moved to modified cautery assisted palatal stiffening operation, or in short, modified capsule, where instead of removing the whole soft palate, we remove a strip of area like so, rectangle, removing the mucosa and fat, preserving the muscle, the underlying muscle, and then we stitch it. So the idea is to gain palatal stiffness so that it will be less fluttering, and there would be increase in airway at the pharynx region. Okay, so like you see in this case, this is post-op 2 weeks after modified capsule. So it's another pharyngo. Of course, if you read book on surgical treatment, there are so many types of lateral pharyngoplasty, sphincter pharyngoplasty. You can read Kenny Pang. He's a Singaporean. He has a book that describes many types of lateral pharyngoplasty. So we like this because the advantages are, number one, less risk of velopharyngeal insufficiency. It preserves the uvula and less risk of cicatricious scar. But again, modified capsule may not be able to treat moderate to severe OSA. Okay, we talk about treatment staging after this. Okay, another case, another surgery, maxillary mandibular, in cases where patient has maxillar and mandibular retrognated and maxillary hypoplasia. Okay, so you can do maxillar and mandible advancement, but this is a major surgery. You would want to reserve this if patient fails CPAP. Okay, there's no obvious big tonsils, no obvious nose obstruction. You have to explain the patient what is the surgery all about, and you have to collaborate with the maxillofacial surgeon. Like shown in this picture of the surgery, you can see the maxilla pushed forward, brought forward, and the mandibles are brought forward so that the airway posteriorly at the pharynx behind the posterior to the base of tongue will be bigger. Thus, may treat the OSA. So now we talk about treatment staging. What is so thing about, we ask for treatment tongue position, we ask for tonsil size. This is because it may be useful in treatment staging. Okay. So this updated treatment staging. Just now we talked about treatment tongue position 1, 2, 3, 4. But in updated one, dia ada treatment tongue position 2A, treatment tongue position 2B, and dia ada 3, and dia ada 4. So for treatment tongue 1, the height with the tongue inside, you can see everything. You can see everything. Treatment tongue 2, 2A, and 2B. This one you can see the arch and part of the uvula. 2B, you can still see base of uvula, but still 2A and 2B. 3, you guys can see part of the soft palate. 4, you just can see the hard palate. Okay? And in treatment tongue staging, in stage 1, okay, the treatment tongue position only 1 and 2 and big tonsils with BMI less than 40. Once the BMI more than 40, regardless, it goes to 4A. It goes to stage 4. Or if the patient has significant craniofacial anatomic abnormalities. Alright? Regardless of treatment tongue position, regardless of tonsil size, okay, BMI less than 40, okay, it is stage 2. Okay, so what is so important about treatment tongue position? Because it may inform us the success and failure rates of UPPP or any pharyngoplasty you perform. So what does it say here? In stage 1, patient with big tonsils and treatment tongue position 1 or 2 only, the success rate is it's good, about 80% success rate. But once it goes to stage 2, the success rate is just 37.9%, 38%. Okay, so what is the take-home message when you see someone with big tonsils, okay, and small treatment tongue position? You may want to say, okay, I may be able to treat, with high chance that you may treat your OSA with this operation. But once it goes to stage 2, stage 3, even stage 4, the chance of success becomes smaller and smaller and smaller. Kalau dah sampai stage 3, it's only berapa? 8%. You want to let the patient go through all the pain. It's very painful. My brother cursed me because of that. No, I told my brother, he has snoring a long time ago, back in 2010. I said, you don't want to wear CPAP, you undergo the surgery. It is painful. I told him everything. Okay, never mind, I want to have the surgery. After the surgery, he cursed me. I said, I told you the operation is painful, but you didn't tell me that painful. He was like, he was like strangulating me because it's so painful. Okay, so, and I received this referral. Again, another patient, orthopedic patient undergoing surgery, and the operation was cancelled because patient has obvious symptoms of OSA. So when I talk to this patient, he has muffled voice. BMI is more than 35. He has muffled voice. I said, oh, maybe big tonsils. When I look into the throat, in the oropharynx, there's no big tonsils. You can see crowded pharynx, but it's because of collapsible redundant mucosa. So the muffled voice is due to that, and he has lingual tonsillar hypertrophy as well. So you think you can treat this patient with surgery? Of course, in private, this is private wing patient. If I want to make money, okay, kita buat capsule, we try how it goes. Dapat dia, oh, it failed. You go for CPAP. Okay, the patient have to go through all the pain. Patient curse you, and worse than that, you may cause some complication. Okay, so this patient, and we request a SIP study. Look at the AHI, 85.1. You do surgery. What stage is this? Maybe 2, Tonsil small, treatment tongue position small, stage 2. So the chance of surgery is about 39.7%. But then the AHI is 85.1. Patient has other risk factors: short neck, thick neck, obesity. How much can you reduce the AHI? I told the patient that you need to try CPAP. Oh, doctor, saya dah try CPAP. It is useless. I cannot sleep with it. Well, try another one. I said, try another one. There are so many factors we can troubleshoot. If you don't, you are not suitable for CPAP. So this is the keyword of troubleshooting. You don't prescribe, and that's it. Leave it to the company. You have to review the patient. If the patient not compliant, is not suitable, you have to troubleshoot. What is your problem? You feel like the mask is not suitable? You feel like too high pressure, you cannot sleep at night? Or is it too dry? You must troubleshoot. So this patient, we put a lot, a big machine, not to say big machine, the recent APAP, auto PAP, and with water yang ada humidification, he slept wonders. He said, oh my god, I never have this kind of sleep. And dia terus setuju nak pakai CPAP. We don't have to do operation. But I tell him, the key of this treatment is you have to use it every day. And you have to break the vicious cycle. You know what is the vicious cycle of OSA? They're sleepy, they want to be more alert, they eat more. They eat sleepy, they sleep more. After eat, they sleep. After your OSA, the vicious cycle. So you have to break the cycle by increase your motivation in life by using CPAP. You use CPAP, increase motivation, you go for exercise, watch out your calorie, and maybe one day you can get great normal BMI, you can repeat the SIP study if the patient do not have any other risk factors. Okay? Kita dah pukul berapa ni? The role of, now this one something like I mentioned about Muller's maneuver kan? Malus Modaber is something arguable. Now we are talking about DISE, drug-induced sleep endoscopy. Okay, is it something important? Does it has a role why we don't do in this hospital?